Continuing the discussion of the patient from last week, we turn our attention to the question of whether or not to give that patient nitroglycerin. As a reminder, and you can see on the screen, we're dealing with a 60-year-old male patient complaining of 10 out of 10 chest pain that radiates to his left shoulder. A little bit of air hunger, the patient's warm, pink, and dry with a blood pressure of 110/70, a heart rate of 40, respiratory rate of 20, and a room air pulse ox reading of 98%. His 12 lead shows a second-degree AV block with 2-to-1 conduction and an inferior posterior STEMI. So you gave aspirin, fentanyl, called ahead to the receiving facility with a STEMI alert. We left it with an unanswered question, so let's answer it now. Would you give this patient nitroglycerin? I'm Angry Bill, and this is Pre-Hospital Wisdom. We understand that medicine's medicine, but pre-hospital providers have special skills, knowledge, and culture that other providers don't have. Let's raise the bar here a little bit. The question is whether or not you would give this patient nitroglycerin. After reminding you that I have nothing to do with your reputation, your protocols, or whether or not you keep your job, I would tell you that I would, based on a couple of preconditions I'll talk about here in just a minute. Paramedics seem to have an irrational fear of nitroglycerin administration. We seem to treat nitroglycerin like it will explode a patient. That's not what nitroglycerin means. I guess it comes from a paramedic school instructor who said that patients would crash their pressure. That instructor heard that from another instructor, and so on, back to the dawn of time, back when paramedics wore sandals. But what does the literature say? Let's do this. Wirtz's group performed a 5-month prospective observational study with 300 patients who were given pre-hospital nitroglycerin. Only 4, that's 1.3%, had adverse effects, and all of those recovered. The mean fall in systolic blood pressure was 14 millimeters of mercury after the first dose and 8 millimeters of mercury following the second dose. The authors report that nitroglycerin, quote, seems to be a relatively safe advanced life support drug. Engelberg et al. Performed a retrospective review of 1,662 patients receiving nitroglycerin over 18 months. The mean decrease in systolic blood pressure was 11.8 millimeters of mercury, and diastolic pressure was 4.0 millimeters of mercury. 12 patients, that's 0.7%, had serious adverse reactions, including a transient drop of systolic blood pressure that was 100 millimeters of mercury. That responded to fluids, and no deaths occurred. Herman et al. Published a weird study with hard-to-follow methodology. They seem to be trying to check whether providers were following the standing order protocol. In any case, I think they looked at 310 patients who received nitro. Of those, systolic blood pressure decreased in 121, but the mean initial systolic blood pressure was 176 plus or minus 44, and the repeat pressures were 164 plus or minus 41. A mean decrease of 12 plus or minus 22 millimeters of mercury was noted. Not much difference there, huh? One patient became hypotensive, but their pressure returned to normal after 300 milliliters of normal saline. Clemency's group published a report of a system that changed pre-hospital protocols to allow high-dose nitroglycerin, consisting of 3 sprays at once for some patients based on blood pressure. That doesn't actually sound all that high to me. And performed a retrospective cohort study to compare pre and post nitroglycerin vitals. 75 patients were included. The average change in systolic blood pressure following multi-spray nitroglycerin was a decrease of 14.7 millimeters of mercury, with a range of minus 132 to plus 59 millimeters of mercury. That's right, an increase of up to 60 millimeters. Only 3 patients had hypotension, defined as a systolic blood pressure less than 100, in the post-administration vital signs. All 3 patients were over 65, were administered multiple nitroglycerin tabs, improved their respiratory status, and had repeat systolics over 100. The incidence of hypotension following multi-dose nitroglycerin administration was 3.2%. Keep in mind, though, that this protocol was for CHF patients with hypertension, not cardiac ischemia patients. More recently, POP reports hypotension in only 2% of cases in his study. That's all well and good, Bill, you might say, but what about inferior STEMIs? Those are specifically dangerous with nitroglycerin. Not necessarily. Robichaud et al. Published a retrospective review of 1,466 pre-hospital STEMI cases, 798 of which received Nitro and had complete documentation. What's the matter with paramedics and documentation anyways? Hypotension, defined as systolic blood pressure less than 90, occurred in 36 of 461 inferior STEMIs and 29 of 227 non-inferior STEMIs. A 30 millimeter or greater drop in systolic blood pressure occurred in 23.5% of inferior STEMIs and 23.8% of non-inferior STEMIs. There was no statistical difference between inferior MIs and other MIs in regard to complication rate. The authors state, quote, patients with chest pain and inferior wall STEMI who receive nitroglycerin do not seem to develop hypotension more frequently than patients with STEMI in other locations. What about the hypocognitive medics who have told me in the last few years that nitroglycerin has never been shown to improve morbidity and mortality? Yeah, believe it or not, I've been told that multiple times. Listen, parachutes have never been shown to improve morbidity and mortality either. Some things are too stupid to test on humans. But here we go anyway. Twiner looked at the current treatment guidelines for ACS, including percutaneous coronary intervention, thrombolytics, oxygen, aspirin, P2Y12 inhibitors, anticoagulation, and Nitro. This article points out that in recent guidelines from the American Heart Association and the American College of Cardiology, nitroglycerin is a first-line treatment for ACS. The 2020 European Society of Cardiology recommends as a Class 1 Level C recommendation the use of sublingual or IV nitrates in patients with ongoing ischemic symptoms. The early use of nitrates has been shown to reduce all-cause mortality, particularly mortality within the first 10 days from onset of symptoms. Nakayama performed a systematic review of research and showed that, quote, pre-hospital administration of aspirin and nitroglycerin by non-physician healthcare professionals is beneficial for patients with suspected ACS. The OPALS study in 2022 out of Ontario found that ALS interventions, including nitroglycerin, are good. Perez is one of the articles that specifically show that nitroglycerin is a good thing. Nitrates reduce mortality at a rate of 4 to 8 deaths prevented per 1,000 doses at 2 days when administered within 24 hours of symptom onset in acute MI. Stop telling people that Nitro hasn't been shown to improve morbidity and mortality. Stop lying to your students and coworkers. Here's another anecdotal example. Every cardiac transfer I run from a rural hospital to a cath lab has nitroglycerin running, usually with heparin. Do you think paramedics have pulled back the curtain on the Nitro conspiracy that physicians don't want you to know about? Don't be silly. What all this means to me is that nitroglycerin is not necessarily harmful and is often helpful. But I will agree that it should be used with care, like any medication. It's a beneficial medication that I should want to give to a STEMI patient. Nitro relaxes smooth muscles, which causes vasodilation, reducing both preload, the venous effect, and afterload, the arterial effect. The result is to lower the myocardial oxygen demand, thus decreasing cardiac ischemia. There's also the benefit of dilating coronary arteries to a certain extent. It is all a good thing. Think of it like this. It can't be all that crazy dangerous. People are prescribed nitroglycerin and take it on their own, without IVs, before a 12 lead is done. Let's get back to those preconditions I mentioned back at the beginning. Hypotension would indeed complicate the care of my STEMI patient, even if transient. So I feel more comfortable giving nitroglycerin to a STEMI patient if two conditions are met. First, I like to have a solid patent IV line that's 18 gauges or bigger. The patient may need fluids, and I don't want to have to screw around getting them into his arm. Related to giving fluids, I need the patient to have clear breath sounds. This is especially true with the pressure between 90 and, say, 130 millimeters of mercury. If their breath sounds are clear, I can lay them flat and open the IV line, pour some fluid in them without immediately drowning them. Nitroglycerin doesn't make blood volume permanently disappear. It dilates blood vessels. So positioning works well to counteract any hypotension. Add a little fluid and we're good to go. The studies above looked at the average decrease in systolic blood pressure. 14 millimeters, 11.8 millimeters, 12 millimeters, and 14.7 millimeters. The Robichaud study found that about a quarter of all STEMIs saw a drop of 30 millimeters or greater, so you have to be prepared for a 10 to 15 point drop and for a 1 in 4 chance of a 30 plus millimeter drop. The question to ask yourself is whether or not you have the 30 points to spare. I've given Nitro to patients exactly like the one in this scenario, with inferior STEMIs. The worst reaction I saw was that the patient puked so hard the vomit hit the back doors of the bus on a horizontal path. I quit giving him Nitro, but his chest pain decreased. Man, my partner that day was bent. In that system, the driver cleans after the call. He was mad. I've had patients drop their pressure into the 80s systolic. They lay flat and the IV gets turned on, then their pressure comes up after a minute or two. I've given Nitro to inferior lateral, inferior posterior MIs and not changed their pressure at all. I know all of that's anecdotal evidence, but it conforms to the literature that I just explained. And we're not talking about right ventricular MIs here, yet. Maybe next week. Let me know what you think, especially if you disagree. I'd like to know why you disagree and see if your reasons make any kind of sense whatsoever. I like to be disagreed with by smart people. One of the most helpful things you can do is send a link to this content to someone you know. Share it, please. Click here for another video or click over on this side for the channel page and all videos. Subscribe's another button around here somewhere. I think it's on the bottom. I'm Angry Bill. This is Pre-Hospital Wisdom, and until next time, stay safe.